وعليكم السلام ورحمة الله. How are you, Dr. Mana?
I'm fine, thank you.
رمضان كريم.
علينا وعليكم أجمعين، كل عام وأنتم بخير.
أنت بخير. Doctor, can we have your slides so the students can take notes along with the lecture?
Just a minute. Is it, I would like always to let them follow the lecture and to send the, you did not ask me before, okay. Just a minute. Can we start?
Yes, we can begin, Doctor. Yeah.
How many? No, okay. السلام عليكم ورحمة الله وبركاته، وكل عام وأنتم بخير ورمضان مبارك. عاد الله علينا وعليكم وعلى الأمة الإسلامية وعلى المجمع بكل خير وعافية. Today our lectures about postmenopausal bleeding. This topic always very important because we are taking care of the woman at the age of premenopause and menopause, and we have to be fair with them because they are the neglected group of the woman, because after the reproductive age group, the woman health started to be less than what we are expecting. The objective of this lecture, we would like you to understand the physiology of postmenopausal bleeding and to correlate the cause of its hormonal profiling test and with the menopause, how the changes and transient period from the normal hormonal levels to the level of the pre and post menopause, and also to know the how to investigate these patients, how to diagnose, and how to treat, and to correlate all this pathogenesis of postmenopausal bleeding with the clinical presentation and what will be the management for each case. What we mean by postmenopausal bleeding. Postmenopausal bleeding usually would be defined for if there is any bleeding or vaginal bleeding after 12 months of amenorrhea in a postmenopausal woman. Usually, sometimes patients will come, especially in the transient period between premenopause and menopause, with amenorrhea of 3 months, 4 months, then she will get her period. Another episodes of 2 to 3 months, then she will get one period. This period is still the premenopause time, but when she is already for 12 months, or 1 year with no bleeding, then all of a sudden she start to develop or complain of some sort of bleeding. We have to take it seriously and to investigate this patient to know what is the cause of her bleeding. It's usually the period for the menopause, starting from perimenopause, menopause, and post-menopause. And each, the hormonal changes started from this premenopause, and usually the average age for the woman to be menopause, 51 years. Usually they will start from 48 to 55 years. But some women, sometimes they can start these symptoms even before the age of 48, from the 40s, and some they might go up to 43 and 44 years. But this is the average. And during this period of time, usually there will be changes in the physiology of the body, physiology level of the hormones, and also the changes in the some sort of emotional changes during this transient period. The bleeding with me, which is the period or the menstrual cycle, it will stop for 1 year. This is what we call it patient postmenopause. And when this bleeding, the hair regular cycle or hair period stopped for 1 year, then she developed bleeding. This is what we call it postmenopausal bleeding. Postmenopausal symptoms of for patients with menopause, usually patients they are coming complaining, which is the most early symptoms, what we call it, and the common vasomotor symptoms, because, and this is because of the starting decline of the normal physiological hormones. Most common complaint hot flushes. Patients will come to you complaining that she's feeling something hot in her face and in her head, and what we call it hot flushes. There will be some sort of cardiac symptoms like palpitation, sweats, usually especially at time of sleep, getting sleepy and getting little bit tired and fatigue with some joint pain. And by the way, this is all temporal symptoms. It will not continue, but this is only during the transient period. It might be for 6 months, it might be 1 year, it might be 2 or 3 years, but it's then all this will be settled after some sort of time, when the body getting use of the normal level of the hormones. Other symptoms, which is psychological effects, patient will start with some change due to the hormonal changes, with depression, anxiety, irritability, and some changes in memory problems or lack of concentration. And all this can be corrected by continuous activity, by continuous exercise, by getting the normal supplements. All this can be avoided and treated before even getting worse, or even to prevent women from getting any one of these symptoms. Of course, there will be some sort of atrophic changes in the vaginal wall, and also in the external genitalia, in the labia minora, labia majora, and the clitoris and the perineal area. It will cause vaginal dryness, and this vaginal dryness causes some sort of irritation and recurrent UTI, and also the most important, urge incontinence, because of this dryness of the urethra and the vaginal area. And this is due to decreased or sudden decreased the level of the estrogen, which is responsible about this all effect. And this is just to remind you, this is the most common symptoms for patients in here between premenopause and menopause symptoms. And this is what we call as postmenopause symptoms, PMS, and this is normal. The one which is abnormal, postmenopausal bleeding, when there is a bleeding, but this changes. This is transient period and expected. And just to remind, hot flushes, night sweats, sleeplessness, stressful and anxiety, some mood change, fatigue, irritability, some pain, and this is all because of sudden decrease of the normal physiological hormones in the body. What happened? Why all these postmenopausal symptoms, or why the woman she go for menopause? This is how the pathophysiology of the changes. There will be few follicles remain in the ovaries, and it start to recruited until almost little or no more follicles in the ovaries. So this will lead to decreased the level of estradiol. Instead of this one from around 800, 600, 700, it will drop until 10 to 20 of the estradiol level in the blood, and decrease the estrogen. This led to decreased estrogen, decrease the progesterone. Of course, when this estrogen and progesterone decline, it led to increased the FSH, and this is the diagnostic of the that the woman she is in the menopause period. When you test for FSH, it will be 13 times fold. And when the normal level between 5, 6, maximum 10 to 12 FSH level. When woman menopause start to get result 50, 60, 100, the level of FSH. At this period, when you see very high FSH, that means even in young women, sometimes it occurs due to premature ovarian failure. To take care also this FSH, this is a sign of ovarian, sometimes ovarian failure. LH also will be high, but less than the FSH will be the one much higher. LH will be more than FSH in case of PCO, but in case of menopause or premature ovarian failure, the opposite. FSH will be the one higher. Usually testosterone level is stable. Either it will be decreased a little bit or it will stay normal level. Women whom not all the women can be investigated unless there is severe symptoms or there is some, but women with bleeding, all of them should be investigated. It's postmenopausal bleeding more likely to be caused by pathological disease, and it must always be investigated. If there is any bleeding, that means for any woman should be investigated. And which woman will be investigated? If she is already after 1 year or 12 months of spontaneous amenorrhea. That means she is in a perimenopause period. Or when woman with postmenopausal age already with bleeding after also 1 year, but she is on treatment of continuous combined HRT. LHRT would be given for her to prevent her from bleeding, but if she bleeds after 1 year of continuous HRT, that means this woman also need to be investigated. And or if there is a normal with no bleeding, but when you for routine checkup or when women coming from slight spotting, complaining of bleeding, and when you scan her by ultrasound, there is thickened endometrial, and usually endometrial in the postmenopause will be very thin, 1-2 cm millimeter. It's very thin. When it comes to be 5 and more, that means this patient need to be investigated for why there is thickened endometrium, and our aim from all of this to rule out malignancy. What is the causes of postmenopausal bleeding? We know it's hormonal changes, but also we have to rule the other pathological causes. Usually, sometimes the most common non-gynecological, sometimes trauma because of the dryness, it causes this bleeding disorders, when there is urethral cornicles or anticoagulation or GIT bleeding, and this is the non-gynecological or the general causes. Gynecological cause is the one which is most common cause of postmenopausal bleeding, vaginal atrophy. Vaginal atrophy causes vaginal dryness, labial dryness, and this led to some sort of a spotting or soreness and lesion, follicular lesion, because of the diminished of the estrogen causing this bleeding. When there is any cervical erosion or changes in the cervical, like cervical changes from either benign or malignant. When patients on any sort of hormonal replacement therapy, and the other, which is the malignant cause, tumor of the reproductive tract, usually most common endometrial hyperplasia. It might be endometrial polyps or endometrial endometrial uterine fibroids or endometrial carcinoma, sarcoma, carcinoma of the cervix, ovarian carcinoma, follicular tumors, all types of tumor of the genitourinary tract should be excluded because it might be the cause of hair bleeding. The causes of benign condition of which is the most frequent and most common cause of postmenopausal bleeding, when the woman complaining of postmenopausal bleeding, Most of the cases will be 90 to 95% cause due to hormonal diminished, and it's the cause of vaginal atrophy, which is atrophic vaginitis, and it's the most common cause of postmenopausal bleeding. So to rule out this one, which is the most common benign cause, before you go for further investigation. Of course, very important, to rule out endometrial cancer, especially when postmenopausal bleeding not responding to the treatment, or when there is thickened endometrium, or long-standing of bleeding. And this is the most serious condition, which should be diagnosed early, and to treat women early, and before it become metastasis. And 10% of all this postmenopausal bleeding can be due to cancer of the cervix or uterus. So it's very important to rule out any malignant causes. A differential diagnosis, which you keep in your mind for any patients with a history of sudden onset of postmenopausal bleeding, as we mentioned, atrophic vaginitis, or atrophic or vaginal atrophy, or vaginal dryness. This is the most common cause of as a benign cause for postmenopausal bleeding. Then you have to go from the hair history to be sure maybe she's on hormonal therapy, and this is the cause of hair bleeding. So any hormonal or extra or exogenous estrogen, which cause thickening or of the endometrial and shedding, and of course will be some sort of bleeding. To rule out endometrial hyperplasia, if it's normal tibia or atibia, endometrial or cervical polyps, which might be, and by the way, this even if it's 5%, but it's common for patient to come with the cervical polyps, and the cause of hair bleeding. And at the end, to rule out the malignant causes, which is the endometrial carcinoma. We will go now for each one of these differential diagnoses in details. What we mean by each one, and how it will be, what will be the symptoms, and how it can be treated. So, so like atrophic vaginitis, which is the most common cause of postmenopausal bleeding, you will know it by bedside examination. You will see dryness of the vulva, and of course, when you examine the patients with the speculum, even she cannot tolerate because of dryness and whiteness of this, because no more estrogen, no more collagen, and it will looks, instead of the normal pinkish, to be like a white and fibrotic tissue. So there will be inflammation, no collagen, no blood, diminished blood supply, led to thinning of this endometrial lining of the vagina. And this is why patients coming from thinning of this vagina by any simple trauma or infection or during intercourse, because of this thinning of the vaginal lining, it led to some sort of even postcoital bleeding. And the cause for this, we know it's because of low estrogen level. Usually, the symptoms, patient will have some sort of dyspareunia, pruritus, itching, dryness, some sort of wind, vaginal burning, and of course postcoital bleeding, and some sort of urinary symptoms, especially urge incontinence or even stress incontinence because of dryness and dryness even of the urethra. A treatment for this case usually depends on how far her symptoms and her age and her lifestyle, and if she is married or not. So always these patients need symptomatic treatment, and also to keep this area always lubricant, moisturizer, use prescribing normal herbal things, which is like water-based lubricants, to help to keep the area fresh and wet, and to give for other cases either to give hormonal replacement therapy or there is some sort of herbal containing some sort of like phytosoya and oral or topical estrogen. It depends on how far or how severe the condition. All this patients will improve, and it will take times. It's not a treatment of 1 week or 2 weeks. It might extend for many years, but to be especially the moisturizing and the topical cream and the herbal. But for HRT and estrogen, it will be temporal time until she passed this critical period of time. And you will see how this healthy vagina, there is a vaginal wall and there is a lining thickened and with a good blood supply. But in case of vaginal atrophy, this glands will disappear, then the blood supply also will be diminished. This is why patients will present with this dryness.
Doctor?
Yes?
Okay, can I ask a question?
Yes, please.
When you say she passed this critical time, you mean that the vagina and the uterus are back to the normal situation?
No, usually it will not be getting back to normal, but usually personal hygiene, very important during this period, because if there is a dryness, that means she's more prone to infection and inflammation. When she keep this area always clean and moisturizing with and there is other, but I don't want to go for details for your at your level now, but there is also now we are using the plasma BRB to build up the vaginal wall and to thicken the lining of the vagina, so the patient will develop more collagen and more blood flow to this area, so it will prevent this dryness and this irritation. But it's very effective and it's long standing because it's not something already estrogen diminished. You cannot keep her on HRT because of the risk of the hormonal therapy. But the things which is local, it's very effective, and it will not be something continuous daily, at least once or twice per week. It will help the woman to prevent this complication. And by the way, it's it looks or it sounds something easy, but it's bothers the woman a lot. Yani, this patient, we should take care of them because sometimes they are suffering and they don't know there is a solution and you can't help them. They think it's something physiological and she should wait and pass through this period of time. No, there is always treatment and to help them until they get past of this critical period of time. And the patient, is it okay for you, the answer?
Okay? Yes, thank you, doctor.
Yeah. For patients who needs HRT, usually there is some cases, they are severe symptoms. Severe symptoms, they cannot sleep, they are severe sweating, severe irritability. It depends. This is the patient where you can shift and give them hormonal replacement therapy. And usually it might extend for 3 months, 6 months, 1 year, but it should not be more than 3 years, just to prevent the woman from her symptoms. Sometimes it extends to up to 5 years. Especially if you rule out any family history, or if she's by herself, no history of any tumors, especially estrogen responding tumor or sensitive to tumor. For this effective, it will improve dramatically and very fast improve vasomotor symptoms, which is hot flushes and the irritability and the palpitation and the sweating, and also to prevent patient from going for osteoporosis. Especially there is some women at the age of 45 or even younger, they go for menopause, early menopause or premature ovarian failure. These patients we have to take care and to keep them also in supplementing calcium and vitamin D to prevent her from osteoporosis. So when you give hormonal therapy and also the supplements from early, you prevent your patients from any sort of osteoporosis. So usually would be low estrogen pill will be given. It can be oral, it can be patch, or for women. Or also some women, they have hysterectomy or hysterectomy early for any reason, cesarean hysterectomy, and affected her causes either early menopause, especially if there is a removal of the ovaries, or if only hysterectomy because of the vagina becomes and the vulva becomes early dryness because there is no uterus to no cervical secretion to lubricant and to prevent the vagina wet. So and other modalities of oral progestin, intrauterine progestin, for like a progestin ring, we call it vaginal ring, to be in the vagina containing estrogen, and who still have their, especially in patients with still having their uterus, not for patients with hysterectomy. The third cause of or diagnosis, when you diagnose their patients with the endometrial hyperplasia, what do I mean? How I will know if it's thickened or not? By ultrasound. Usually ultrasound will show thickened endometrium. What I mean, it's more than 5, because usually it's normal for women during the reproductive age, and it will be 5, 6, up to 10. But for women with the postmenopause, usually it will be, the endometrium will be very thin, 1.5 to, when it becomes 5 and more, we have to investigate this patient. How? And our aim to rule out hyperplasia, because this hyperplasia can be simple or complex, with or without atypia. So this is why it's usually patients with thickened endometrium. Most common symptoms, bleeding. She will present with postmenopausal bleeding, and usually diagnosis will be by dilatation and curettage. This dilatation and curettage to get sample. First, to remove this thickened endometrium, which is this one. See, this is endometrial hyperplasia. When you go for dilatation and curettage, DNC, I mean by DNC, D dilatation and C curettage. You will go through this is the cervical canal by dilatation. You cannot go inside the uterus until you dilate gradually the cervix, because it's very tight and closed. When you dilate the cervix, you can go in by curettage and remove all this thickened endometrium. So patients, when you remove all this, you will prevent her from keeping continuous bleeding, and at the same time, you will send this endometrial curettage to the pathophysiology lab to see what is the type of this endometrial. Either it will come to you as a normal proliferative endometrial tissue, or it will come to endometrial carcinoma or endometrial hyperplasia with atypia or without atypia. And each one of these diagnoses, it will guide you to go for the next step of management. So see how this is the normal, usually will be normal looking. This dilatation and curettage can be done by 2 ways, either directly by dilating the cervix, then making curettage blind procedure, or nowadays the most important to go by hysteroscopy. So you will go by dilate the cervix, and by hysteroscopy to visualize all the endometrial cavity and to see if there is any abnormality, if there is uterine polyp, if there is intrauterine myoma, or if there is just thickened endometrial or abnormal growth. So you can get sample directly from the abnormal site, not just blind by DNC and just getting all and send all. But when you see, you can, it will be more advanced, but not all the hospital and not all the doctors having these facilities of hysteroscopy. But this is the alternative to go just for DNC. And the decision usually how to treat this patient depends on the histopathology result. If there is atopia, that means this patient at high risk of endometrial cancer. If there is no atopia, if it's just endometrial without atopia, these patients can respond to medical treatment, especially progesterone, to treat and at the same time prevent bleeding without risk of the endometrial carcinoma. But our aim is to rule out not to start treatment for patients, and at the end you will discover this patient not responding because it's endometrial hyperplasia due to endometrial cancer. Treatment depends on the cause. In cases of endometrial hyperplasia, that means the standard treatment, and this is endometrial hyperplasia without atopia. You will start progestogen, and this is usually the standard treatment. If we give oral contraceptive to take care, it will be for short period because it's combined estrogen progesterone. Or if postmenopausal bleeding heavy, patients can respond to intrauterine device containing progesterone. And this not for postmenopause bleeding or premenopause. It will not be just as a contraceptive. We give her as to prevent menorrhagia, especially for patient doesn't want to go for like hysterectomy, or she's not a case of endometrial cancer, and she wants to try another modalities of treatment. This very active method of treating postmenopausal bleeding or irregular bleeding in menopause, because it contains progesterone, and because causing atrophy of the endometrial cavity, so there will be no more proliferation or thickening of the endometrial tissue. This IUCD, or what we call it Mirena, because it's contain hormonal intrauterine device, contain this progesterone and cause atrophy of the endometrial cavity. If there is any endometrial thickening, usually by hysteroscopic resection of, as we mentioned, to remove the endometrial tissue, and causing ablation by, and this led to atrophy or burning of the intrauterine tissue, and this will prevent recurrence of the endometrial hyperplasia. In case of endometrial atypical hyperplasia, usually this patient cannot will use the intrauterine device if she cannot tolerate surgery with follow-up if she will respond or not, or if she's already menopause, complete her family, and with no response to the medical treatment, the advised for her to go for total abdominal hysterectomy with bilateral salpingo-oophorectomy to prevent her from continuous bleeding and losing of causing anemia and other disease due to continuous bleeding, and also her general health and her social health because of this continuous bleeding. So they advised not to go for hysterectomy, and if it failed the medical treatment, even if it's not a case of for case of endometrial carcinoma, straightforward to go for hysterectomy. But I mean for patients with endometrial just hyperplasia but failed to respond to that treatment. When there is that fourth cause of bleeding, so endocervical or cervical polyps, and this this is how to see this one by hysteroscope. This is cervical at the endocervical polyp, and this is, you can see this one in the uterine cavity. This is protruding from, this is the fundus, and this is with the stack, this is uterine polyp, and this is how to remove by hysteroscope resection of this polyp. It will remove this polyp, and this is after, and this will help this patient to prevent her from the cause of her bleeding. Usually cervical polyp either it will be from the endocervix or it can be ectocervix. You'll be see this protruding through outside the uterus, and usually it's due to overgrowth or hyperplasia of focal region. Usually polyps comes, it's a benign, and due to growth of polyps increased, especially if still patients with the in pre and menopause period, still there is a hormone, but most of the uterine fibroid, if especially at the postmenopause, will regress in the sides because of diminished of the estrogen. Some of this uterine or cervical polyp, if it's external, not endocervical and not intrauterine, can be removed in the clinic by hysteroscopic polypectomy or by sometimes grasping and twisting. So the stuck will be to a continuous twisting will lead to separating of this polyp from the uterine, from the wall of the cervix. Endometrial carcinoma, and see how it looks like when you see by hysteroscope. There is different overgrowth in one side than the others, and it looks pale overgrowth, and this is how it looks. That means if you clue that might be it's endometrial carcinoma, different than the normal looking into internal uterine cavity. It looks fresh and flushy, but in cases of endometrial carcinoma, the shape it looks pale and with some overgrowth of the endometrial tissue. And this usually usually result from any post-estrogen, and there is some sort of estrogen continuous stimulation of the endometrial lead to overgrowth and hyperplasia of the endometrial tissue. And the most common symptoms and early symptoms is postmenopausal bleeding. Patients will come early with the symptoms of bleeding. Usually they don't know that what's the cause. A carcinoma of the uterus, or most common gynecological malignancy, and how to diagnose by hysteroscopy and endometrial biopsy. This is a gold standard, not only just a blind DNC, the dilatation curettage. We advised endometrial biopsy through hysteroscopy. You will get the sample by hysteroscopy and to diagnose the cause of her bleeding. And the treatment usually, if it's carcinoma, the best and the treatment of choice, this patient should go for total abdominal hysterectomy and bilateral salpingo-oophorectomy. I will remove the ovaries because she's already in postmenopause. If you just get out the, it might cause regrowth or metastasis, and this ovaries patient will present again with the symptoms of pelvic mass, and will discover this is due to hair ovaries. This is why it's so advisable to remove the uterus and the ovaries. And this is the treatment of choice for any patients diagnosed with endometrial carcinoma. Of course, it depends on the stage. If this patient can go for further treatment like radiation or chemotherapy or hormone therapy, it depends on what stage of her endometrial carcinoma. Who is at risk of, and which is the most serious condition, who's at risk of endometrial carcinoma, because this is the one which we want to work on it and to prevent it, because it's the most serious condition or medical and surgical problem. Risk factors, as you know, obesity, because it will be extra, and there will be adipose tissue, which converted to androgen. Androgen will give you more estradiol, so it will be more estrogen in the body, and more estrogen, that means affect the endometrial tissue and causes this endometrial thickening. When there is late menopause, that means some of the women, they will reach to 50, 52, 53, and still they are getting their period, even if it's intermittent. But late menopause, because that means women with continuous exposed to more estrogen. Other medical disease like diabetes mellitus, and you know this diabetes mellitus because some of them there will be insulin insensitivity, and increase this insulin will convert it to androgen. Androgen causes, as you know, in cases of PCO, and imbalance of the hormones and continuous anovulation will lead to continuous estrogen unopposed by progesterone. Nulliparity, because of it's one of the also patient can present with this one of the risk factor, and patient due to breast disease or breast cancer, and she is in tamoxifen. Other family history, it's one of the most important risk factors. Patient family history of breast or colon or ovarian carcinoma or uterine fibroids or sarcoma. All this can be ruled out from the history, but this is all well-known risk factors for patient to develop endometrial carcinoma. How you will get, and this is very important for all of you to know, because how to take a history. Most of the patients, before even you go for further investigation, you will know, you will have your differential diagnosis from the history. History usually when it starts, duration, pattern, amount, and frequency. I think all of you know very well what we mean by if there is a pain, a weight loss, a change in the bladder, if she's in hormonal therapy, tamoxifen, if there is, as we mentioned, breast cancer, family history. Very important to know all this history. When we go for physical examination, this is as a routine abdominal examination, and for palpitation of any pelvic mass, for pelvic examination by a digital examination, and also by as a bimanual and by speculum examination to rule out any cervical erosion or polyps, and if there is any detection of any nodulity in cul-de-sac by rectovaginal examination. In investigation, the most important investigation, which is abdominal or transvaginal ultrasound, endometrial biopsy by using hysteroscopy or by direct DNC. Even by hysteroscopy, it's a sampling of the endometrial and at the same time treatment, and diagnostic and therapeutic. In the hysteroscopy, getting sampling, and at the same time you can do removal of the endometrial thickening or the polyps or the causing ablation. Pap smear, of course, very important to do for all patients with the postmenopausal bleeding to rule out any, not just by hysteroscope and endometrial biopsy to rule out endometrial carcinoma, but by pap smear to rule out cervical, any abnormal ascus or abnormal cervical tissue. A transvaginal ultrasound, usually this is the machine, how it looks. And this is how the ultrasound, this is either it will comes as a mass, and this in cases of postmenopausal, to think if this thickening due to endometrial carcinoma or due to uterine fibroid. By ultrasound, it will give you all this measurements and site and also if there is any other multiple or uterine like tissue or fibroids or polyps, it will be shown by ultrasound. If the thickness of the threshold, usually as we mentioned, below L5, but if it's more than 5, that means we have to rule out endometrial carcinoma, and sometimes it's just thickening because of continuous effect of the estrogen, and just by treatment or removal and by curettage of this endometrial tissue, patient, and when it comes back normal pathology or not endometrial carcinoma, this will be one of the treatment. In case of pap smear, this is how to get pap smear, and this pap smear just by brush or by spatula to rule out cervical cancer, and this is as a routine, even not only for patient with a postmenopausal bleeding, it's a screening test for evaluation of cervical tissue, because sometimes you don't know what's the cause of hair bleeding. Is it, especially in postmenopause with cervical dryness, is it the cause from endometrial or from the cervix? This is how to hysteroscopy. It's direct hysteroscopy. It's diagnostic and also therapeutic. And as we said, it's called standard investigation. You can see this is how it looks normal, fresh, red blood endometrial cavity. And this hysteroscope led to allow you to go through the cervix after dilatation of the cervix to visualize the uterine cavity. And also you can see the ostium, the two ostium, the opening of the two uterine tube. And this is how it looks like normally. When there is endometrial carcinoma, usually you will see abnormal growth of the tissue from one or two or different anterior, posterior, up or down of the uterine cavity. And this is how to think, to start to think how it's in these patients will take sample, but it might be endometrial carcinoma. In case of uterine also hysteroscope, you can see some to visualize the uterine cavity. There is some bulging and protruding. This is what we call it uterine polyp. And this, when there is a uterine polyp, usually patient will present with a continuous abnormal uterine bleeding, because it increased the surface area of the uterine cavity. This is why patient keeping bleeding, but this is a benign condition, but need to be treated, and resection can be done by, if it's inside the uterine cavity, by the hysteroscope. But if, and this is what we call a polyp. But if there is outside the uterine wall, which is, it will go by abdominal surgery, not the only one removed from inside the uterus by hysteroscopy is the one intrauterine. But the one outside or in the intramural need to remove by laparoscopy or by laparotomy. And this is benign, not malignant. Endometrial biopsy, this is if we'll go over to take sample just by dilatation and curettage, which is DNC. A tissue sample would be taken from the endometrium, and this is the endometrial either in the clinic to get sample by piped, or in the OR, because you cannot dilate the cervix unless patient under sedation or general anesthesia, and to remove by the biopsy. It looks like small curity or spatula to remove the endometrial cavity thickening of the tissue, and at the same time send it for taking sampling and removing. And this is if there is no hysteroscopy, this way can also be done. Sometimes this one, endometrial pipe, this is in the clinic, just to take tissue from the uterine cavity and to send for histopathology before patient go for further investigation. How to manage this patient? History and examination indicate the cause, but generally we should treat any patient with postmenopausal bleeding as a case of malignancy until we approve otherwise. Assessment of blood loss, to be sure, and this patient sometimes it's very heavy and they can come, they need hospitalization and blood transfusion and IV fluid and hydration. So very important to take care of this cause. In case of atrophic vaginitis, usually treatment, local treatment, as we mentioned, by estrogen cream, or estrogen ring, or estrogen tablet, moisturizing. This will help the patients and to keep the skin of the moist and soft. In case of HRT, usually estrogen will be given as a hormonal therapy, and you will select for patient, not patient with any history of cancer before, and it's for short period of time, just until she passed the period of the severe transition period. Some patients, they will use it 3 months, 6 months, then her symptoms improved, and so you can stop her from this treatment, and this will improve the symptoms and prevent osteoporosis and also prevent cardiovascular disease. A cervical polyp, and we discuss it and how to remove polypectomy under hysteroscopic guidelines to remove any uterine fibroid. Endometrial hyperplasia with atopia, and this is the same, either in this patient to go for progestin therapy, by injecting Profera or progesterone, and this is around 150 micrograms to be given each 3 months. It will prevent it as a contraceptive, and at the same time preventing endometrial hyperplasia. But this patients will be giving this injection. It will stop hair bleeding and prevent endometrial from proliferation. So our patients can go for Mirena, and this is how it looks like, the IUCD with this it's thickened or cap that contain progesterone. The other cover IUCD, it will be straight, thin, without this cylinder. This is small cylinder. It contains, it's very small, but it looks in the slide big. It's small and thin. It releases a steady amount of progestin, which led to help and causing atrophy of the endometrial tissue and prevent the patient from bleeding. Endometrial hyperplasia, and we said this is to do total abdominal hysterectomy plus bilateral salpingo-oophorectomy, and this is for case of patients of postmenopause with abnormal histopathology like endometrial cancer, or if there is any endometrial hyperplasia with atypia. And this is as a summary for all the management for what we discussed, just to make it easy: if atrophic vaginitis, local treatment, cervical polyp removal, endometrial polyp or cervical same by visualization by hysteroscope and removing, simple hyperplasia, just treatment by progesterone or by oral or intrauterine device. If there is hyperplasia complex without atypia, these patients can get benefit from oral progesterone or intrauterine device. If there is atypical, this patient needs to go for abdominal hysterectomy, just to prevent her from a risk of progression to malignancy. And in case of endometrial cancer, this is a clear cut, and this patient should go for total abdominal or vaginal hysterectomy with bilateral salpingo-oophorectomy. And this is, it depends on the stage, if she will go for other adjacent therapy. Okay, this is all regarding postmenopausal bleeding and menopause woman. And remember, always patient postmenopause, they are suffering from hot flush, and always what AC, they need the AC to be on, fan, always they are suffering from sweating and from hot flushes. I hope my lecture you enjoy it. It's very important for all of your family, for your mothers, for your friend, yeah, not friends actually, because your friends are young, but family. Sometimes they are they need to be educated as for woman health. All these symptoms should be treated as a symptoms, and if there is a bleeding, patient should go and ask for help as early as possible. Thank you, and if you have any questions, most welcome. Yes, Noura? Can you hear me?
Doctor?
Yes?
I have a question.
Yes, please.
Doctor, can you please repeat how diabetes mellitus produces the endometrial carcinoma, please?
Yeah, in cases of the patients with PCO, if you remember, the patient with PCO, usually you will, when any patient with polycystic ovary disease, you will ask for fasting blood sugar, for hemoglobin A1C, and for insulin level. All this because there will be some sort of what we call it insulin insensitivity. All these patients will be more prone to diabetes mellitus in the later on. It's one of the risk factors. And this insulin, it will convert or to increase the androgen level. This androgen level, it's a cycle. it will lead to PCO and continuous secretion, or increase the level of LH and increase the level of estrogen. But this is why the estrogen level will be high. That means the woman will be more exposed to high estrogen and exposed to more endometrial carcinoma.
Oh, okay, thank you, doctor.
You're welcome. Okay, are you done? Okay, thank you. And
Thank you.
okay, have a good day, and رمضان إن شاء الله عليكم جميعا مبارك.
Thank you, doctor.
Thank you.